Nice. So today we have rehab science, Tom. So Tom, can you introduce yourself for those who are not familiar with you?
For sure. Thanks. First of all, just thanks for having me on. Yeah, so Rehab Science is kind of my alter ego online, Instagram and YouTube, but I'm an orthopedic physical therapist. I've been in practice for 18 years now. I finished my DPT back in 2007. It's crazy how fast the time has gone. And I've been in orthopedic physical therapy pretty much that whole time. A couple years where I was in an insurance-based clinic, but kind of quickly realized that wasn't the best fit for me. So I transitioned over to cash pay, and really education has always been my real passion. It took me a while to figure that out, but I transitioned to the academic setting, and for 10 years I taught in a kinesiology undergraduate kinesiology program. So I was responsible for a biomechanics course mostly, but I also taught a pain science course that I developed while I was there, a therapeutic exercise course. Prior to becoming a physical therapist, I was a exercise science major in my 4 years of undergrad. And in high school, I was a martial artist and gymnast. So I was not really super interested in school. In high school, I actually didn't have great grades. I just didn't do homework. But I was very focused on Taekwondo. I had my second degree black belt in Taekwondo, and I was a gymnast. So I look back on that, and I didn't realize it at the time, but martial arts was so powerful in terms of my kind of development as a mover. I think being barefoot and just all the single leg control and things that we did in martial arts and gymnastics, the strength side of it, the body weight strength, I really am grateful for it because it has influenced a lot of what I do as a physical therapist and just in my own health and how I move and the health of my musculoskeletal system. So there's I think a lot about martial arts and gymnastics in the way that I operate as a physical therapist and how I treat patients. So yeah, that's kind of went from being an athlete. I think a lot of physical therapists are like this. You're an athlete, maybe you study kinesiology or exercise science in undergrad, and then because of that athletic background, I had a knee surgery in high school and went to physical therapy. So that introduced me to the profession, and it just ended up being a right fit because of my interests in exercise, but also having had a rehabilitation uh, experience myself with the knee surgery. It was just a good mix of all of my interests. So I that's how I ended up in physical therapy. I was always interested in orthopedics. I really enjoyed biomechanics and thinking about kind of how our joints operate from a mechanical standpoint, all the convex concave rules and all the back in the day we used to think of manual therapy. I have a real heavy my residency was in orthopedic manual physical therapy after PT school, and back then manual therapy was very mechanical. It's more mechanical in nature. You were thinking about, oh, if I did this posterior glide on the shoulder, it would influence their mechanics in this way. And now we know manual therapy is probably not that specific, more neurophysiological in nature. But I did it in the beginning really enjoy the mechanical kind of side of rehabilitation. And now I'm interested a lot in pain science and just the complexity of pain. And my mom's a psychiatric nurse practitioner, so I'm also kind of interested in just the nervous system and mental health in general and how that ties into the development of persistent pain states. So that was a long answer, but that's kind of my background.
I love it. I love it. So, uh, I guess this is my first question because we kind of talk about it before I start recording. Like you have like a whole lecture of biomechanics, and if I remember it correct, there's one or two pain science lecture. So, what are the most common feedback you get from those lecture?
Yeah, those are, it's so fun to see those lectures. I just put them up on YouTube years ago. I left my full-time teaching job in 2019, and I think I put the lectures on right after that. So
Yeah.
maybe right before COVID, something like that. But yeah, it's the whole semester of biomechanics lectures. And then, like, the pain science, I need to put up more of the lectures. I only have two on there. I kind of lost my ambition. But yeah, the feedback's been amazing. It's so cool over the years to see, it's a combination of undergraduate students, so like kinesiology students, exercise science students, who are taking biomechanics, and those lectures end up being the feedback a lot of times is that they're really helpful to them and understanding the material they're already being taught in their class, sort of as a supplement. But I also get a lot of different practitioners, a movement, health and fitness practitioners from trainers to Pilates and yoga instructors, physical therapists, chiropractors, just people who are coming in there and wanting to brush up on different topics because I organized my biomechanics course. Sort of there was an introduction and then there was a lecture on each joint region. So there's a shoulder lecture, a spine lecture, and so people can kind of come in there and learn about one topic. Actually, the one that's most popular is the gait lecture. So a lot of people, that was something I was really interested in for a long period of time, was just looking at gait analysis and all the events and phases of gait. And so that can be it's a lot to memorize. When you're learning gait, like the human walking cycle, if people listening to this haven't learned the human walking cycle, it seems really easy, but it's quite complex. There's all these different events and they're marked by different little key things, and you have to look at each joint and what muscles are active. So human gait is actually really interesting and quite complex. So that lecture actually probably gets it has the most views and probably gets the most feedback just in terms of helping people. So that's cool.
Nice, nice, nice. So, uh, out, outside of like the lecture, although I love it, I was like, I rewatched it like a few weeks ago, and it was because sometimes like student watch like these lectures like, oh, it's so boring, I'm gonna fall asleep. No, it was so easy to watch, like not like so easy, but it was probably very interesting because I would just keep watching, watching, watching for hours and not fall asleep.
That's amazing. I don't even know why that is. It's interesting because those lectures, I need to go back and redo them because I didn't have a good mic at the time. It was just I don't even think I don't even think I had a mic hooked up. It was just the mic on my computer. So it's like you can hear the fan running. It was an old laptop and it would have to cool itself. And I should go back and just really do an upgraded version and make them better. But, now they've been on YouTube for so long and they're in the algorithm and getting views. So even if I re-recorded them, they probably wouldn't do as well. But
Yeah,
yeah, it's been really neat to see something like that. It's always cool when you put something out there, you create some piece of content and you never know how something's gonna do. You try to, right, we have all these strategies of, oh, what's the title and thumbnail, all these different things, but
yeah,
sometimes you just don't know. And so it's
yeah.
pretty neat to see something help people, and just to keep getting the feedback years, it's 4 years or something now that those lectures have been on there. So it's pretty neat.
Nice, nice. All right, I'm gonna ask you something about like low back pain, and I think that's probably the main reason I start following your Instagram, like probably during COVID. I can't remember, it's way too long. So, uh, although I said it's correlated low back pain, I'm just gonna say the most interesting one I like the yeah, whatever, is SI joint pain. So, I know it's complicated, it's complex, it's not necessarily SI. There's a lot of stuff, performance, whatever, like fascia, sib ischium, whatever. But like, what are the common cause for SI joint pain?
Yeah, I think SI joint pain is an interesting one because there are so many different structures. The low back is tricky because so many different structures can create pain there. I mean, you were mentioning some of them. Like when you look at the SI joint region, a lot of people blame their back pain on the SI joint. A lot of people in the general population, I'm not sure why that is, but a lot of general people in the general public are familiar with the SI joint, which I think is interesting. And maybe it's because they've been to practitioners who talk, because unfortunately, right, like different PTs and chiropractors will talk about, oh, your hips are out of whack or whatever, and your SI joint's out, and I'm going to put it back. And we know nowadays that that's not really true because the SI joint only moves 2 to 4 millimeters. It doesn't move very much. It's got a ton of ligaments that surround it, but it can be a pain generator. And so, but you've got your facet joints right there, your L4, L5, L5, S1, those facet joints at the bottom of the spine. You've got all of the muscles in that posterior region, like you said, the piriformis and your glute med and min, and your hip joint even can refer to that region. So it's tricky to sometimes figure out, is this truly an SI joint? The gold standard they'll say in the research is if the person has an SI joint injection, if they go in and a doctor under imaging gives an injection, like maybe a lidocaine injection, and if that takes away their pain, then you can be that's going to allow you to be the most certain that this is probably pain related to their SI joint. But I think when you look at, I'm trying to think about, the people I've seen over the years that seem like they had SI joint. The thing that you usually hear is that there was some sort of uneven stress to one of their legs. Like, right, that's the kind of textbook um cause that will be talked about as like you always hear the like they stepped off a curb and didn't know. We've all done that before, right? Where you're walking and you don't visually see a change in the ground and you anticipate it differently and your leg kind of gets jammed and the thought there is the force goes up your leg through your tibia, through your femur, and your SI joints attach your sacrum right in the middle, kind of the bottom of your spine to your pelvis, to the ilium bone of your pelvis. So if you jam one leg, that can kind of jam the pelvis on that side and could irritate the SI joint. Like I said, it doesn't move much, but it does have, a number of ligaments that surround it. There's mechanoreceptors, there's nociceptors. It's something that you can have pain in that region for sure. So, that's kind of the textbook cause that you hear about is some sort of uneven stress. I can't think that I've actually had a patient who's come in and has said that, in 18 years. I can't think if I've actually had someone who said, "Oh, I stepped funny and it started hurting right here." I think often I've had females who are pregnant, right? Like you hear that, like they are going through pregnancy and it's said that this hormone relaxin in the third trimester it's designed to kind of loosen up the ligaments around the pelvis. And so sometimes you hear, I've had female patients who have pain in the SI region during pregnancy. So that's one. And then when it comes to the more mechanical ones, it seems like a lot of the people I've had who have had pain in the SI region, it seems like it's more often some sort of stress to their low back. Like maybe it was like I had someone recently who was, doing these sandbag workouts, these kind of intense workouts down at the beach with a group with these heavy sandbags. And he was doing almost like a Russian twist type exercise for his abs. And it seemed like he had more of an SI presentation. Now, again, we have our provocation tests. That's kind of what we do in the clinic now, right? Like we will put people through these different tests that are meant to stress the SI joint. And if you have more and more of those that are positive, then you can be a little more certain in your hypothesis that it is coming from the SI joint. So that's the way we'll kind of look at it. And he was the last person I remember where some of those tests were positive. Back in the day, when I first came out of school, my final rotation for 16 weeks was at a clinic where they diagnosed a lot of SI problems that I don't think were actually SI problems, but they were doing it with movement exams. And I don't know if you ever were trained in those, but they were like the ones where the person would bend over and it was a lot of palpation and movement. So you'd
Oh yeah.
palpate their PSIS and their sacrum and you'd look for the timing of the movement.
Yeah, yeah.
And we know now that those are pretty flawed tests. Like they aren't super reliable or valid. Like you can be fooled a lot by your eyes. And so, or it was asymmetries. Yeah, we'd look like I remember palpating like, okay, what is the ischial tuberosity, your sit bones on either side? How do those compare? How does your PSIS compare, ASIS? And you'd look to see like, oh, I can see that there's a anterior rotation of their pelvis on this side, or a posterior rotation, or in flare and out flare, up slip, down slip. Like we used to look at all those things, and in the beginning of my career, I used to tell patients, like I used to really think that was how I was trained initially, was to use my visual cues to make assessments of people, and really, and in that region, the pelvic region, really based a lot on movement and palpation and visual cues. So I remember thinking people had in flares and out flares and up slips and down slips and working on treating those. And I think now we know that those tests really probably aren't that great, and provocation tests are the better way of figuring out. So, if you're someone who has pain in your low back, the SI joint will typically kind of hurt near that bone. You can kind of feel it at the backside of your pelvis. It's called your PSIS, but that little bone, people will reach back there and, oh, it kind of hurts there. And sometimes it'll radiate down a few inches into the buttock. If you have pain in that region, it could be your SI joint. It could also just be your low back, referring into that region. And so if you go see someone who's kind of up to date on the evidence will put you through different provocation tests where they're usually kind of moving your hip or pushing on your pelvis and looking to see if it reproduces your familiar pain in that region. And if they're doing something like that, that's how you can kind of figure it out. I think actually the good thing though about I'll stop talking in just a
It's
second.
okay.
The good thing about back pain is that, there's so many different things that can cause back pain, right? Like you could think about your intervertebral discs, your facet joints, the muscles and tendons in the region, the ligaments, the SI joint, the hip joint can refer into that region. In a lot of cases, it doesn't really matter, right? It doesn't really matter. Most of the time, these things will get better with time and kind of the same general exercises if you're making sure to pick things that don't provoke you and irritate it. So, right, like a lot of low back pain cases get better initially with hip biased exercises. Like, so it might be hip kind of mobility and stretching exercises, like you're stretching your piriformis and your glutes and your hip flexors, and then hip kind of strengthening exercises like fire hydrants and side lying hip abduction and bridges, and also adductor strengthening the groin muscles. A lot of times that can be helpful, but and then as the person's pain gets better, you start to transition gradually into spine biased exercises, gentle mobility exercises, and then starting to load the spine and strengthen it. So I think while the what's causing someone's pain can be complex and we don't always know with 100% certainty what it is, the good news is that the same general recipe gets most people better.
Mm. I kind of agree on that because, like you mentioned, I'm not a physical therapist, but because I was so fascinated by movement assessment, so I learned SFMA a few years ago and being pretty familiar with that. And after learning SFMA, like I know like SFMA can't really like I'm trying to f find the right word, but whatever. SFMA can't really figure out like what's causing like low back pain besides hip mobility or thoracic mobility. So there's a system in UK called kinetic control, and that teaches the whole palpation of the SI. So like putting your finger on PSIS and sacrum to see like how much they move. All and yeah, the upslope, downslope,
Yeah.
all those stuff. So I mean, till today, I still use those stuff. Like, I'm not. I have to say, I agree with you. Those tests are like so hard.
Hmm.
Like, how do you feel like so minimum like movement? There's like probably like two, not even like 2 or 3 centimeters, like 2 or 3 like millimeters.
It's tricky, right? And you don't know the person's baseline movement. So we
Yeah,
know the
that's the
human,
case. Yeah,
right? Like the human body's already naturally asymmetrical,
yeah,
and people want to think that it's symmetrical. It's not. The movement system's really asymmetrical.
yeah,
We have a foot, like there's all these things that are different, right? Like our feet are different sizes. You can have differences in how your hip joint is set up and how much internal extra rotation you have. But humans are just, it's normal to be asymmetrical. So I think the
yeah,
tricky thing is when people come into rehab you don't know their baseline. Like you know how they're presenting when they have pain or an injury, but you don't know their true baseline. So the movement tests, you're assuming that they're symmetrical in you know, what you determine from that test. So it makes it tricky.
Well, so now you said that, like it makes me feel tricky too, because yeah, human body are not like meant to be like they are meant to be asymmetric.
Yep.
So, but at the same time, most of the reason that causes a SI joint pain is asymmetric. That is kind of
Yeah.
funny.
Yeah. 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 I think, probably a lot of what happens. It's this chicken or the egg kind of debate, right? Like I used to, definitely when I was early on as a PT, I would look for movement impairments. And I would think I'd probably be more likely to think, oh, this movement impairment is the cause for their pain. And I think more often now, I tend to think the pain changes how you move. So a lot of times people's movement will go back to normal when the pain gets better, And so I think with something like SI joint pain, you often find asymmetries in the person's hip range of motion. When you're palpating the symptoms that come out of their left side versus the right side, like you'll find differences. And I think more so these days, I like to, I don't really say, I will point those asymmetries out to the patient, but I try to do that in a very non-threatening way. I don't want to, whereas I think early on in my career, I was less careful about that, and I might have made the person feel a little worried about asymmetries and the fact that they were making them think they were causing their problem. And I think more so today now, I think often pain changes how you move because there's guarding and your body's kind of protecting itself. And once you can get the pain to go down, oftentimes those changes, potential asymmetries, will go back to closer to normal. Because, right, we still do, when we assess people, we're kind of assuming symmetry, right? Like when you measure someone's hip range of motion, we have textbook normals, like, oh, okay, we want 45 degrees of external rotation, 45 degrees of internal rotation, which nobody ever has. But, right, you're 120 degrees of hip flexion. You're looking at these things and assuming that they're pretty close to textbook, but you got to take it with a grain of salt because you don't know their true baseline and were they perfectly symmetrical. But that's kind of what you're I still tell that to patients like, hey, I just had someone the other day, like he had low back pain, and it was actually kind of a tricky one. Like, was it SI? Was it more of a facet pain? Was it a discogenic pain? There was no nerve referral. It was localized to his back. But he did, when I assessed him, his right hip was quite limited with flexion compared to his left side. So when I had him supine on the table and brought his hip up in flexion, there was a hard end fill, and it definitely didn't move through the same range of motion. And so I mentioned that to him that that side was limited in range. But again, also acknowledging that I don't know his true baseline and maybe that was always there and maybe it doesn't matter. But so I'll often tell it to patients like this is a difference and it's something that we'll kind of track and potentially work on. But does it actually matter in his situation? Hard to say. It's a finding, but is it just his natural asymmetry? I don't know for sure.
Nice, nice, nice. So, um, like you mentioned, though, like those tests aren't aren't the best. But so nowadays, how do you assess that?
Yeah, I pretty much use the provocation tests. Like I'll go through and look to that's really, I think a lot of rehab actually what works best is um, implementing tests that are designed to reproduce the patient's familiar symptoms. So that's most of, I think, my whole practice in a way is someone's coming in and they're talking about having a particular pain. And so sometimes it's movement or position type testing, that I think can be useful. Like, you're asking the person, are there particular movements or positions that trigger your symptoms? And so that's a clue, right? If they have something like that, if they say, oh, when I sit for long periods, it hurts, or when I extend my low back, it hurts, if I arch my back, they might say, so there could be postural kind of move like positions, or there could be movements, and so I will often watch people do things like that. But I'm looking at it more. I mean, I am, of course, paying attention to how they move. Like, what's the quality of their movement? How far? What kind of range of motion can they go through? Um, but I'm also looking at does it reproduce their familiar symptoms? And that's true with all the other testing. So then once I get in and palpate an area or apply stress tests, like in the case of the SI joint, we're taking the person's hip through different positions or we're compressing their pelvis. There are all these provocation tests. You're looking at the idea is can I provoke their familiar pain? And I think if you can find tests, movements, or positions that provoke the person's familiar symptoms, it's more likely that you're going to find a solution to help reduce their pain. The hardest ones are when someone comes in and you can't find anything that reproduces their symptoms. And sometimes I think that can be good news. Most mechanical musculoskeletal issues get better just naturally with time. And so I think sometimes people are coming into rehab as things are kind of winding down, and then it's of course it's harder to provoke their symptoms. So, but with a mechanical pain, I think the SI joint is true of this, and most musculoskeletal conditions, you're looking at um, movement tests and provocation tests to reproduce their familiar symptoms, and then that helps you come up with sort of a clinical plan, a kind of a game plan for them.
So, uh, like you mentioned, we we kind of assume movement should be symmetrical instead of like asymmetric. So, like, yeah, this is hard. So, what, like, nowadays, like, if you watch an athlete move, like, they're gonna be asymmetric.
Hmm.
They're gonna be asymmetric no matter what. Like, every athlete is asymmetric. So, how do we know that are they in the safe range or like they're on the edge?
Yeah, I think it comes down to pattern recognition, right? This is what makes people good at different things is just having worked in a particular area for a while and recognizing patterns. So if you are thinking about athletes, there are some athletes that are very dominant in one arm or one leg, like baseball pitchers, right? Like they are always doing something with that throwing arm. And so we see great asymmetries in their shoulder range of motion. And if you work in baseball and like throwing sports all the time, if you're a coach or a physio or whatever, like you're gonna know that. Like those patterns are just totally second nature to you. They're obvious. So that there's a lot of that asymmetry that contributes, elevates the athlete's performance, and you're not going to try to change it. Like they used to, this was something though that occurred early on, right? Like baseball pitchers in their throwing arm, they have way more shoulder external rotation than they do in their non-throwing arm, and very limited internal rotation. Like their humerus changes if they start throwing from a young age. Their humerus bone actually will twist the joint itself, it changes. And so now, but early on when this was first researched, that wasn't known, right? There was a starting point to this. And so practitioners would try to normalize, make the shoulder more symmetrical in their throwing arm. Because normally we have about 90 degrees of external rotation, about 70 of internal. But these throwers, sometimes they'd have 165 degrees of external, maybe 10 degrees of internal. So they had this huge, what seemed like a major, they were way off from normal. And so practitioners would try to increase their internal rotation to try to get it back to more of a normal position. And what ended up happening was they threw the ball slower. So it affected their performance. And so now they talk about a total arc of motion of 108, is it 180? 160. Anyways, there's now we look at the total range of motion from maximum internal to maximum external. So yeah, right, we're around 160. You've got 90 of external in the normal shoulder and uh, 70 of internal. And then you look at the throwers, they still will have about around that like 160, 170 because maybe they have, like I say, maybe they'll have 160 of external rotation and they'll have 10 of internal or something. So but it took a while to get to that point. And I think you have to, if you are working with athletes, you want to spend some time learning from people who have been in that sport for a while so you can kind of get some information on what are the patterns in those types of athletes. Like I said, I grew up in martial arts and gymnastics. Those are much more symmetrical sports. Like there are, like with certain kicks, like I would use my hips differently. Like I was more like certain kicking techniques would be better with one leg than the other. But those sports are a little more kind of more ambidextrous in a way. So I ended up being a little more symmetrical in my body, I think just because of how it adapted the way that I train. But I think if you're going to go into something where you're working with athletes, a particular athlete, maybe you're making a career change and you're going into sports and you don't know anything about that sport, definitely take your time to learn what those patterns are because you don't want to treat the many of those athletes, you don't want to treat them like the average person off the street because the demands are just totally different. And they're if they start from a young age, they've probably adapted and do have some kind of interesting asymmetries.
Yeah, yeah, nice. So, uh, since we're talking about asymmetry, um, I always think scoliosis is an interesting one because how the spine rotate, flat side bend. So, can you share your thoughts on like maybe how the scoliosis can affect human movement?
Yeah, scoliosis is a super interesting one and one that I've covered a number of times in the past. I was telling you before we got on recording, it's not, I wouldn't say it's a specialty area for me. There are definitely physios out there who really specialize in the treatment of scoliosis. And, scoliosis is an interesting disorder in that there's ranges of it, right? Like you can have really mild scoliotic curves. Like when most people come into physical therapy and they say, I have scoliosis. When I go and look at their back, it's like super minor. Like sometimes it's difficult to even see visually, you know? So, but then you have the really severe cases where the person has such a severe curve in their spine that it compromises their lungs and their ability to breathe. And so those cases often, they begin in adolescence. And sometimes you'll see individuals who have surgery where they go in and straighten the spine and put in rods. They used to be called Harrington rods, or maybe different names now, but basically straighten the spine out so that the person's lungs aren't compromised and they can breathe and function normally. But like I say, most people, I've only met one or two people that have had that surgery over the years, so you don't see as many of those cases. Most people have a more mild form of scoliosis, and scoliosis is an interesting thing because the spine moves, is a triplanar, has the ability to move in all three planes. Usually they'll talk about scoliotic curves as moving in those planes as having a side bend component and a rotation component. And they most of the time, so scoliotic curves are create kind of a C curve in the spine, and they have a side that's, if you imagine like a C, you have a side that's kind of the inside of the C, that concave side, and then you have the outside that's the convex side, and they're named by the convexity, if I remember correctly. So if you have somebody who has a left scoliotic curve, you could say say they had a left thoracic scoliotic curve, it would be a convexity on the left. So it would be like they're side bending to the right, So you imagine, and then what you'll see is that oftentimes if they have a lower scoliotic curve somewhere lower in the spine, they may have an opposite one up higher in their upper thoracic or neck because most of us, if something's causing us to kind of bend one direction, we will right our head. So we'll bring so if I have a left scoliotic curve that bends me to the right in my thoracic spine, I will then bend my neck back to the left, side bend it to the left to keep my head straight. So you'll often see these, and there's lots of pictures. Like if people just look up scoliotic curves on Google, you can see all different kinds of images. And rehab around it, it's often unrealistic to think that you're going to totally permanently change the person's spine and that curvature, especially if as they get older and the spine kind of becomes more set in its ways. But there are, different practitioners. One that I've highlighted on my account times before is called the Schroth method, and they're practitioners who really focus on different breathing and sort of muscle activation techniques, where you're looking at kind of cueing the person through, you're cueing them to activate their spinal muscles in a way that they can learn to kind of straighten it back out. So there's there's a big cognitive element to it and different exercises. Like if you have that C curve, you might stretch the concave side. 'Cause you imagine if you're kind of bent one direction, one side will kind of potentially can get tighter and shorter, and then the other side sort of lengthens. So you're kind of thinking about, can I stretch one side, lengthen it, and then strengthen the other side and work on trying to help pull the person back to straight. The other interesting thing about scoliosis, like, is that a lot of people have scoliosis and don't have back pain. So I always try to help people understand that there's lots of interesting things about the human body that seem like they would be bad and cause pain, but they don't always. And mild scoliosis cases there are a lot of people who have those who don't have any spine pain. So it's something just to keep in mind. And if you do have a scoliosis and you have back pain, try not to stress out about it too much because sometimes people will think, oh, I'll never be able to get rid of my pain if I can't permanently fix the scoliosis. A lot of times spine pain goes away and the scoliosis stays there. So you just have to keep those things in mind when you're going into it.
Yeah, yeah. I have scoliosis,
Oh,
like
well,
not compared to those who wear like those what is it
braces and
called? Yeah, wear
yeah.
those braces. I'm like probably mild, like and and if I never s- squat, if I never sprint, I probably won't even like find out I have scoliosis.
Yeah, it's asymptomatic if you don't do those things.
Yeah,
There's certain things
yeah.
that trigger. Yeah.
It just happened after I start like lifting, after I start sprinting, then there's something I feel like weird, some pain. But if I don't do that, it actually never bothers me.
Hmm.
So yeah, I agree. Like probably everybody have some sort of like scoliosis nowadays.
Yep. Yeah, if you had a tool that you could really measure it really specifically, we'd probably say a lot of people don't have like, or they do have like a little bit of a, it's like that
Yeah,
asymmetry kind of thing again. A little bit of, we're
yeah.
not probably all perfectly straight.
So sorry. So again, for those, how do you know it's scoliosis or not? Or like the pain is because scoliosis or it's from something else?
Yeah, I think that's hard to say. You know, that one's even trickier than the SI joint because there's not really, there's not like a specific kind of scoliosis provocation test or something like that, right? Like it's just spine pain and you're trying to figure out what contributes to it. And there are lots of things that can contribute to pain, right? Like, so to me, you know, I think if somebody had back pain and they had an obvious scoliosis kind of right in the region and it fit with their symptoms, you know, then I think I would be more likely to explain to them that the two things could be linked. But I still, you know, a lot of what I would do treatment wise, especially in the more mild cases, would still be pretty similar to the person with just general back pain who doesn't have scoliosis. You know, I think you're implementing a lot of the same principles and kind of strategies to help reduce their pain. Now, maybe you do find out if you found out that helping to cue them if you notice that when you take them out of the scoliotic position it really reduced their symptoms, that maybe could be kind of your test, right? Like maybe that's kind of your test. Like, but you have to do that really carefully and without biasing them because if the person knows they have a scoliosis and they're blaming their back pain on scoliosis, and then you tell them you're going to do something maybe with your hands or you're going to cue them in a certain way to help them kind of straighten the curve, that may naturally lead them into believing that it's something that's going to fix them and make them feel better. So you have to do it. You have to kind of keep the patient blind to it. You know, sometimes you try things with patients and you don't right away explain what you're doing because if you lead them too much, well, of course, they might feel better just because they believe it's going to help them. And that, right, like the whole placebo side of things is a huge aspect. So sometimes you've got to kind of just be quiet and try things with people and then ask them what's happening with their symptoms. So, you know, but that could be kind of a test. Like if somebody had an obvious scoliotic curve and they had pain in the region, maybe you know, sometimes what I'll do is I'll have people sit and I'll use kind of my arms on, like I'd stand to the side of them and maybe I'd pull kind of up on one shoulder and then push over with my other hand kind of on their rib cage. And maybe I'm looking to see, can I manually take them out of that curvature? And then without leading them, maybe just ask them like, does this change your symptoms? And maybe that could kind of serve as a test. Like if you take them out of that position and their pain gets better, well then yeah, well maybe in your mind you're thinking, okay, this position of their spine, maybe this is contributing to their pain and maybe I can try to then implement some techniques where I'm, you know, like I said before, kind of stretching the concave side and improving control and strength of the convex side and teaching them things they can do on their own to bring their body out of that position. But, I think outside of that, a lot of people with more mild scoliotic curves just present with kind of almost like general back pain. And so I will often get questions on this on my social media, like, hey, I have scoliosis, what should I do? And I think, it's worth seeing a practitioner who specializes in the area and having them kind of look at the things I'm talking about, where how much does that curve seem to contribute to your symptoms? But I think over the years, I've seen a lot of people with these more mild cases also get better with a lot of the strategies and exercises I would prescribe to someone with, just more general back pain in a situation where they don't have scoliosis. So I think you can follow a lot of the same principles and still see really good improvement, like with the spine mobility exercise, like looking at, okay, my spine moves in left and right side bend, it moves in left and right rotation, it moves in flexion extension. I can go through and test those things on myself and see, like, do I look relatively symmetrical with left and right side bend, with left and right rotation? Like, is there a big restriction there? Can I bend over through flexion through mostly full range of motion? How does my extension look? And then I can think about, okay, my spine moves in all three planes of motion. Maybe I can add some strengthening exercises that kind of challenge each of those planes of motion. And I think sometimes when it comes to the body, you can just kind of keep it simple like that and not worry so much about what exactly, like what tissue or structure exactly is causing my symptoms. Just what are my symptoms? What aggravate my symptoms? What can I do right now to help reduce them? And then can I go through and look for impairments like in mobility and strength? And if there are any that are really obvious and glaring, then I'll implement some exercises to kind of address those. I think if we just keep it simple like that, sometimes it makes the whole process easier.
Yeah, it makes sense because think about it, if it's really like mild scoliosis, the spine turns like maybe this way. It's actually easier for them to turn this way and harder for them to turn that way.
Yep.
And it's gonna be like side bend like this. So makes
Exactly.
sense.
Exactly. You see those things fit together, right? Because yeah, if
Yeah.
you see someone, they have a side bend and they'll usually have a rotation. Sometimes you'll see that kind of rib hump where their ribs will
Yep.
pop out more on
Yep.
that side, and you can see that rotation. So yeah, if like the rib hump is out on the right, when you go to test them through rotation, you'll probably see an
Yeah.
asymmetry because they're already kind of rotated right. So you might see they get a ton of left rotation and hardly any more right rotation if they're already in that movement. So I think those are things to look at. So like if the person has back pain, it's in that region, and you notice that they have a rotational component, then maybe you look at as you're assessing range of motion, you're asking them, you're looking at, well, how far can they move, and does that change their symptoms? And if one direction lessens their symptoms, then well, maybe that is a part of your initial treatment plan because usually the goal in the beginning is always to kind of reduce pain symptoms so that the person can function better.
Nice. 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 Well, I guess that's all the question I have for you today. So for those who are interested in what we're talking about today, known as SI joint pain, scoliosis, asymmetry, where can they find you and where can they find those like really good posts?
Yeah, for sure. Well, I'm just at Rehab Science on Instagram and YouTube. On YouTube, it's the easiest to find a lot of these posts because I have different playlists for each body region. So the spine playlist, I have a scoliosis YouTube video that has a few exercises people can try. Again, it's not the tricky thing about creating content online is that while it can help a lot of people, it's not specific to anyone, right? It's like, so I always say, you can try things. A lot of conditions can be self-managed with general kind of exercises that target the area. But if you don't get better, that's where going to see someone for an evaluation, because then somebody can really measure you and figure out what would be the best thing for your situation. But on YouTube, I've got that spine playlist. There's an SI joint video, there's a scoliosis video. On Instagram, I cover these topics as well, but you just have to kind of scroll down the page and look for them. People can always DM me. Like a lot of times people will DM me on Instagram and I can send them the links for these things. And then I also have a book. Like I have a big 500-page book that
New
in
book,
the
right?
what's that?
New book, right?
Yeah, it came out May of 2023, so I'm actually getting close to 2 years, which seems like it's flown by, but that book has three-phased comprehensive rehab programs with pictures of me doing the exercises. So each body region has its own chapter. So if you were looking at back pain kind of things like this, scoliosis, SI joint pain. The low back pain program in my book is the one it's the most comprehensive because so many people have back pain. I really tried to make that one just include as much as possible. So that is a great resource. That's more similar to what you get from a physical therapist because it's three phases. It's gradually taking you through a program. But again, it's not specific to you because I didn't evaluate you. So people have to always realize that general things you find online, they can be super helpful. Like a lot of times they really can be pretty helpful. If you just read about the condition, kind of think, okay, this sounds like my symptoms. It in most cases, rehab exercises are very safe to try. Like, right? Like people ask me sometimes, is this safe to do? Most of the time it's super safe. So, but if you don't get better, that's when maybe you give it 3 weeks. And if your symptoms don't reduce at all, not that they're totally gone, but if they haven't reduced at all or have gotten worse, well, then you go see someone for an evaluation. That's always the gold standard. It's like seeing someone who can talk to you, listen to your history, talk about your symptoms, actually test you, and then determine these are the things that are best for your situation.
Nice, nice, nice.
Well, see, well, hey, thanks for having me on, man. This is awesome. Always fun you can probably tell I like to talk about this stuff. That's why I enjoy, so grateful to have the different platforms where I can put out educational content. I really enjoy talking about it. So thanks for having me on.
Nice.